morning, students. My name is Angela Rufai, a resource person. I will be taking you NSC 505, Maternal and Child Health Nursing 3, the course outlines. In this course, we will be considering the following course outlines: obstetric emergency, roles of nurses and midwives in the management of obstetric emergencies, abnormal labor and related midwifery care, youth-friendly facility, and lastly, we will be talking about adolescent health. Now, what is obstetric emergency? Obstetric emergencies are life-threatening medical conditions that occur in pregnancy, during pregnancy, and after labor. And this could be classified under the following headings. We have obstetric emergency during pregnancy, obstetric emergency during labor, obstetric emergency after birth. Now, what are the obstetric emergency during pregnancy? Examples are miscarriage, ectopic pregnancy, placenta previa, placenta abruptio, placenta preeclampsia, etc. What is miscarriage? Miscarriage is a condition whereby the pregnancy is terminated before 37 weeks of pregnancy. This is usually occur at the first trimester of pregnancy. We have ectopic pregnancy. It's a condition whereby the pregnancy is situated, implanted outside the uterus. Implantation of pregnancy could occur at the fallopian tube, it could occur at the ovary, and sometimes it could be in the abdomen. A condition whereby the pregnancy is not situated inside the uterus at the fundus of the uterus, we refer to it as ectopic pregnancy. We have placenta previa. Placenta previa is also a kind of obstetric emergency whereby the placenta is implanted abnormally in the uterus, especially when the placenta is covering the internal house of the cervix. We refer to it as placenta previa. Then we have placenta abruptio, that is a sudden separation of the placenta from the bed of the uterus. Then we have preeclampsia, that is abnormal increase in blood pressure that is characterized by pedioedema and sometimes protein in the urine. This could result into serious complications like eclamptic fits, and it could also result into death if urgent attention is not given. We have obstetric emergency during labor. Examples are shoulder dystocia, prolapse umbilical cord, rupture of the uterus, eclamptic fit, and fetal distress, etc. Now, what is shoulder dystocia? Shoulder dystocia is abnormal position of the fetus shoulder during the process of labor. When the fetus is unable to navigate through the pelvic bone and the shoulder is abnormally positioned during the process of labor, we call it shoulder dystocia. In this case, the process of labor is arrested and the patient is unable to progress and deliver the baby through spontaneous vaginal delivery. In this condition, the patient will benefit from cesarean section in order to deliver the shoulder dystocia. Another condition we have prolapse umbilical cord. Prolapse umbilical cord is a condition whereby the umbilical cord is presenting before the fetal part. Ideally, the fetal part should be the one to be presented during the process of labor. E.g., when we have a cephalic presentation, that is, the head is coming out before the other part of the fetal body is coming out. But in a condition whereby the cord is coming out before the fetal part, this could result into compression of the cord, which may result into fetal heart rate deceleration, and it could also result into fetal death, and this could result into obstetric emergency. We have rupture of the uterus. So the uterus might also rupture during the process of labor, and this is also known as obstetric emergency. It is a condition whereby the uterine muscle is ruptured during the process of labor. This could occur as a result of abnormal or abnormal use of uterotonic agents like oxytocin, ergometrin, and in some conditions whereby the patient had also undergone cesarean section before, so the patient is also prone to rupture of the uterus. Now we have eclamptic fit, that is the tonic-clonic jerking of the pregnant woman during the process of labor. Probably the patient had preeclampsia before during the pregnancy. This could result into eclamptic fit. Then we have fetal distress, a condition whereby the fetal is in distress when the fetal heart rate is below or above the normal follow. And the normal follow of the fetal heart rate is between 110 to 160. A condition whereby the fetal heart rate goes above 170, 180, or below 100, the fetal is in distress and the fetal must be delivered as early as possible through the cesarean section. So in order to prevent fetal death. And we have obstetric emergency after labor. Number one is postpartum bleeding, postpartum fetal uterine infarction, and postpartum blue moon. Now, what is postpartum bleeding? Postpartum bleeding is a condition whereby the patient loses more than 500 ml of blood during spontaneous vaginal delivery, or a condition whereby patient loses more than 1,000 ml of blood during the cesarean section. We have postpartum fit, that is jacking, tonic-clonic jacking of the patient after labor. This will occur when the patient had suffered from eclamptic fit during the process of labor or pre-eclampsia during pregnancy. The patient may also experience postpartum fit. We have uterine infarction and we have postpartum blue moon. Roles of nurses and midwives in the management of obstetric emergency. What are the responsibilities of midwife to prevent or to minimize obstetric emergency? Number one is early identification of signs and symptoms of obstetric emergency. As midwife, we should be able to identify the vulnerable women, the signs and symptoms, e.g., hypertension, dizziness, vaginal bleeding, abdominal pain during the pregnancy, electrolyte imbalance. All these conditions must be identified during the pregnancy and give appropriate measure to prevent obstetric emergency during pregnancy or after labor. We should encourage early antenatal booking. We cannot achieve the first step without encouraging the early antenatal booking. If pregnant women book in antenatal early, the midwife will be able to identify those who are at risk to experience obstetric emergency. Then we have to provide support to all pregnant women without any bias, without any discrimination, especially the vulnerable ones. Then we have to encourage adequate rest. Pregnancy requires rest and exercise. We should be able to inform pregnant women that they should be able to balance between rest and exercise. Abnormal labor unrelated midwifery care definition. Abnormal labor is a failure to meet milestone and limit of normal labor. If the pregnant woman is unable to meet the normal labor sequence, or the pregnant woman deviates from the normal labor sequence, we refer to them as abnormal labor. What are the types of abnormal labor? Abnormal labor could occur as a result of slow progress, or the progress could be arrested and precipitate labor. Then what are the causes of abnormal labor in pregnancy? Number one is the passage, that is the pelvic architecture, the passenger, the power, and the patient and the provider. Now, what is the passage? The passage is the pelvic architecture of the pregnant woman. So we have different type of pelvis. We have gynecological pelvis, we have android pelvis, we have petellated pelvis, etc. So gynecological pelvis is the most preferable pelvis. So during labor, and other pelvis could result into complication or abnormal labor. We have the passage, which is the fetal itself. The size of the fetus determines the kind of labor the woman will experience. When the fetus is too big, measuring more than 4.5 or 4.0, so during the process of labor may result into abnormal labor and may warrant cesarean section during the process of labor. We have the power of the uterus. The uterus should be able to contract in order to enhance the progress of labor during the labor process. Then the patient power, the patient itself, that is the readiness of the patient, and the provider, which is the expertise, knowledge of the midwife. Now, management. What are the management of abnormal labor? The first one is early screening and identification of labor abnormality, prompt referral for expertise care, provide support to the family, and provide adequate knowledge. We should be able to screen the patient and identify those who are at risk of abnormal labor, e.g., those who have abnormal pelvis. We should be able to identify them during the pregnancy, and those who have fetal abnormality, like big baby during the pregnancy, that may result into abnormal labor. We should be able to identify them and provide adequate care before it results into abnormal labor. In the case whereby we are unable to manage these patients at our own facility level, we should be able to give prompt referral for expertise care, either to the secondary level or to the tertiary level. And we should be able to give support to the family to identify abnormal labor. And we should be able to provide adequate knowledge to the pregnant women. Youth-friendly facility definition. Youth-friendly facility are a set of services designed to address the barriers faced by youth in accessing high-quality sexual and reproductive health services. We have quality services, quality facility. Now, what are the quality of facility for youth-friendly facilities? So the facility must be safe. That is, there should be a safe environment for youth to access the facility. It must be friendly to the youth. It's not a facility whereby the youth will not be, have confidence to go there. So it must be safe for the patient, for the youth, and it must be friendly for the youth. Supportive care, there must be supportive care for the youth, and there must be a respect for the youth, and there must be confidentiality. Adolescent health is the range of approaches to preventing, dictating, or treating young people health and well-being. Health-related problem in adolescents, we have road traffic accident, we have drowning, we have violence, alcohol, drugs, mental health, and etc. And these are my references. Thank you for listening.